Dr. Herrick, it's very nice to meet you. Thank you so much for granting us this interview. I've been really looking forward to it.
Well, thank you. I'm looking forward to it as well. Yeah, I feel honored to be asked to talk about my career and things I've gone through. Yeah,
Yeah, no, thank you so much. And so, I guess with that, we will just kind of dive in. And thank you for sending along your CV. So, this evening we are honored to be having this interview with Dr. Tim Herrick, who served. And correct me if I'm wrong, but you're also currently serving as a pulmonary critical care physician at Cape Cod Hospital. Your CV said 1999 to present. So, is that accurate?
yeah.
Okay.
The present was 2025, so
Oh,
I
okay.
did ultimately retire in 2025. Yeah,
Well, congratulations on your recent
yeah.
retirement.
Thank you, thank
Yeah,
you.
from the sounds of it, you had a very full career. So, yeah, Dr. Herrick went to medical school at Wake Forest in North Carolina, and then after that, also did your residency there. Is that correct?
I did undergraduate and medical school
I
at
see.
Wake Forest, and then my residency was at New York Hospital, Cornell Medical Center.
That's right. Okay, and then your fellowship was at George Washington in
George
DC.
Georgetown, right?
Georgetown. Okay, okay, great.
Georgetown. Yeah.
Thank you for
Just
clearing that up. Yeah.
across town, right? Exactly.
All
Yeah.
right, great. So I guess with that bit of background, I would love if you could reflect on your experience. Really, if you could start from what got you into medicine, what drew you to the profession, and what was it like when you were a medical student?
Sure, sure. Yeah, so I'm the first in my family in the medical field in any way. Um, my dad was a pipe fitter, and my mom, was a homemaker. I was the oldest of three. Um, I guess I started thinking about something in the medical field probably in high school, and in particular, I know that my experience working in my dad's pipe fabricating shop made me feel like I probably didn't want to do what he was doing. So, so after a couple of rough summers doing that, I focused on sciences and had particular plans to try to go to med school. So I buckled down and actually when I chose a college that I thought would give me a good shot. Wake Forest had its own medical school. So I thought, going there undergraduate might give me a step up. So
Okay, great. And so, what was the application process like for medical school at the time?
yeah, it's quite a bit different than it was today. It was sort of similar in terms of the way it was for undergraduates that you maybe applied to 3 to 5 schools. I know nowadays, I mean, people are doing like 25 or 50 or crazy, crazy numbers. So it was like 3 to 5 schools. And then you just, hoped you'd get an interview. And, if you didn't, some folks went ahead and did, some kind of postgraduate work. Some folks went immediately out of the country. It was, common for folks to go to Mexico, Guadalajara, to Europe, to Grenada. So there was a lot of pressure. It was more common for folks to go kind of straight through. And my daughter's a physician, so I know now that it's not uncommon for folks to do other things and come to medicine a little bit later. But but when I was doing it, it was, you finished undergraduate, went right to med school, and you went right to residency, and was right on from there. And if you got derailed in any way, it was kind of a problem. So yeah.
I see. And actually, that brings up a very interesting point. So you've kind of, I think, seen some of this with your daughter, having gone through it more recently. But for the people who would go out of the country if they weren't able to go to a U.S. med school, or maybe they just wanted to go out of the country, where would they practice thereafter? Would they come back to the United States, or do you know what that was
Yeah,
like?
they almost always came back,
Uh-huh.
and then they'd have to look for residency programs that would accept them.
Mm.
Um, and sometimes it wasn't in the easiest places to train or work. And I have to give credit to these folks who did it because some places, I mean, the curriculum was in the language of the country.
Mm.
If you went to, Mexico, you better bone up on your Spanish. I had a colleague who went to Italy, and I mean, fortunately, she spoke Italian at home. So, well,
Mm.
but if that wasn't the case, then it was, not only you're dealing with the rigors of the medical curriculum, but it's in a different language.
I see. Okay. Very interesting. So, anyways, going back to you. So you ended up at Wake Forest, and then do you remember things like how much your yearly tuition was and kind of what courses you were taking? If you could kind of expound on some of that.
Sure. So, yeah, I know this quite exactly because med school was $5,000 a year.
Wow.
Yeah, right.
Hard to
Yeah,
imagine. Yeah.
right. And it was a time when prices varied north to south in the country. Um, Actually, one of the reasons, I mean, my family didn't have a lot of resources. One of the reasons I went south is because I could get a good education for almost half the price. So, but yeah, so undergraduate was 4,000, med school was 5,000. Um, the The curriculum was sort of the basic curriculum at the time. It was first 2 years were completely didactic, in the classroom. So it was more or less an extension of your undergraduate life in many ways. You're in the classroom every day. And it was the typical, gross anatomy in the anatomy lab and cell biology and, biochemistry and, all the usuals. But you didn't really get exposed to much clinical until the third and fourth years.
I see. Okay. And then, as you were a medical student, when did you start thinking you would move towards something like critical care, pulmonary medicine, general medicine in general when you were doing your
Sure.
residency? How did that decision come about for you?
Yeah, so it seemed like at the time, the decision tree was surgery or medicine. You're going to do a surgical subspecialty or you're going to do, medicine and maybe a medical subspecialty. So I just really enjoy the intellectual challenge of medicine. I guess that's why I was drawn to it. At the time, I wasn't thinking pulmonary critical care at all. Um, so that I was more drawn to medicine. Um, I would say there are some kids in the class who um, maybe they had a parent who was a physician or in healthcare or something like that, and they they had other ideas. It was going to be radiology or it was going to be radiation oncology or something like that. But for me, it was like, am I going to be a surgeon or going to be an internist? And I really just liked kind of the intellectual challenge of medicine.
I see. Okay. And then that is what t ended up taking you to New York, where you did your residency. And can you speak a little bit about how, what your residency was like how big your residency class was, what kinds of rotations were you doing, how many hours a day were you working at a time,
Sure.
kind of what was the culture of training?
Sure. No, definitely. So for anyone in my era trained in internal medicine, there were a number of programs that were kind of lauded as being kind of like in the trenches. You're going to get down and dirty and you're going to see it all and you're going to do it all. And so there are places like, well, Boston City Hospital and there are Bellevue in New York and, Grady down south, which is associated with Emory. So and on the East Coast, those are the really kind of uh, in the trench kind of training experiences. So I certainly wanted some of that, although I did interview at Boston City Hospital and realized I didn't want all of that. Because those guys, I mean, they were drawing their own blood, they're starting their own IVs. There was no transport service. So if your patient needed an
Mm,
X-ray, you were wheeling them to X-ray. I
yeah.
was like, okay, that's a little bit too real. So yeah, so I had a brother, a friend whose brother actually had finished training at New York Hospital. And he said, you really should take a look. And so I did. And luckily I got in. So it was a pretty big residency program. I sort of had forgotten how many were in it, although we recently have just connected because we're coming up on 40 years of finishing.
Oh, wow.
And it turns out there were 36 internal medicine residents. So it was a straight every third call rotation, which means you're either on call, you're coming off call, or you're going back on call. And your call nights were, I would say, on average about 34 hours. So you'd start at 7 o'clock in the morning, go all night long, usually not sleeping, and then a full day. And then, they might cut you a break and try to get you out at 4 or 5. Um, and that's the way it was. We rotated. So New York Hospital is an interesting place to train because it's on the Upper East Side of New York, now a very affluent area. But at the time it was kind of mixed to some extent. I mean, you definitely attracted Park Avenue types. And there's a lot of celebrities came to the hospital. As a matter of fact, the Shah of Iran had just been there before I started my residency.
Oh,
Um,
wow.
yeah, and but it also had what else had an emergency room that was open to the general public and took all comers. So, but you had a service wing to the hospital, and then you had kind of your private pay wing. So you got kind of a mixture of both. But we did, standard rotations, general medicine rotations, ICU rotations, emergency room. There was also New York Hospital has an affiliation with both Sloan Kettering and the Hospital for Special Surgery, which is an orthopedic hospital. So um, so you could rotate through, doing other electives and things, after you got through your internship. Yeah.
Okay. And from just like a day-to-day perspective, obviously your 34-hour calls, of course, I'm sure it was extremely taxing, but what would that time period entail? So like when would your round start? Whenever you were going around, writing orders, were they handwritten or were they on a computer? What did that kind of a typical day look like for you?
Yeah, no, we were all analog. Everything
Okay.
was written. Everything was written. Yeah, so you'd probably get to the hospital around 7 o'clock. You might a pre-round on some of your patients, at least folks you know you heard might have had issues overnight. You'd get a brief sign out from whoever was on call about anything that had transpired, and then you'd start your formal rounds with the attending, like at 7:30 or 8 o'clock. And those rounds might take you maybe an hour and a half or 2 hours to go through everyone. Um, and then you just start getting the work done for the day, um, which would include things like, if so the blood draw team came through and they try to get all the blood, but if they didn't get somebody, you'd have to go try it yourself. Or if you needed people who needed new IV lines, you'd have to go do that yourself. Um, and then all the orders were written, um, all the notes were written. And then, um, yeah, you'd speak with consultants. Sometimes you'd actually go down and do some radiology rounds. If there were, images you wanted to take a look at, you'd go down and you'd grab a resident and pull out the films and go through the films and that sort of thing.
When
And
you
then
say pull out the films, just to clarify for our audience, you mean pull out like a like translucent
a
sheet?
physical, a
Yeah. Pull,
physical
yeah.
X-ray film. And
Yes.
that was one of the more trying parts of being a resident is actually just finding the films. So there's a big file room, and the x-rays are all in these jackets, and there would be multiple studies in these jackets, and it was handwritten on the jacket what was in the jacket, the latest study. And patients might have multiple jackets, and sometimes they just migrate, meaning that someone would say, well, we got a case presentation. I'm just going to grab these films so I can do the and then you go to look for the films and they're not there. So that's one thing that the current, EMR system has helped tremendously, is just that kind of wasted time just tracking down x-rays. Yeah.
And so I guess going along that topic, do you think overall, do you remember when the EMR was first introduced in your practice? When do you remember what it was like to move from completely analog handwriting things to now having everything on the EMR? And around when did that happen for you?
Yeah, I mean, that was well into my career. Um, uh, yeah, we were handwriting. Oh gosh, trying to figure the year. After I finished my training at Georgetown, I went to practice pulmonary critical care in Connecticut for about 10 years, and then went to Cape Cod Hospital and spent the next 25 years there. So I was probably a good at least 10 years into
Mm.
private practice at Cape Cod Hospital before that came to us. And it was difficult because as we know now, you know, many of these systems were really not ready for prime time when they were effectively kind of forced on the medical community. I mean, I always think it would be nice if like Apple or Microsoft had just like gotten involved. We would have had one product that really worked well, but it's been painful over the years. It's better now, and I think most people are you can at least have learned to work with it. But it was yeah, there was multiple different versions. The idea was that, oh, we're all on this electronic medical record. We'll all be able to see what's happening, with each other's patients. We'll be able to talk to one another. But that didn't happen for a long time, and still it's not completely happened, as you probably know. So it was very trying, really.
Yeah, so I guess growing pains that continue to plague
Yeah,
us to this day,
yeah,
and
yeah, no
and
doubt.
and were do you remember the sentiment among your colleagues when things were moving electronic? Like, were people excited about it? Were they hesitant? Did they just flat out have disdain for it? Like, what were the conversations like?
They were generally not happy about it just because they they weren't user-friendly interfaces.
Hmm.
Most hospitals have gone through multiple iterations of these, medical record systems. I think Epic has come to dominate a lot of places now, so that's one of the more common ones. But we all experienced multiple different generations of things that just didn't work that well. And then early on, what you had in the hospital wasn't what you had in your office. So, those two systems didn't talk to each other. So it was a lot of work, and a lot of added expense too, because no one was like subsidizing you to add this new piece to your practice, so you had to work harder just to pay for all the upgrades,
I see. Okay.
right?
Um, and so going back to your time in residency, so you walked us through what a typical day looks like in some ways, and then I'm also really curious, like how many patients would you be carrying as a resident at one time, and was this concept of like patient caps where you're limited by the number of patients you can care for during a particular time period? So in terms of volume of work, how was that for
Yeah.
you in training?
So I would say the average intern load might have been like 8 to 12 or so. Um, there were no admission caps. For example, if you were on call, you just got what came.
Mhm.
I mean, sometimes the next day, if things are really out of whack, someone might pick up a patient or two of yours just to kind of balance it out. So it was in that neighborhood. Um, you know, what that, in a typical team was like a resident, maybe three interns. And so what that meant is when you were signing out to somebody, that person might be responsible for like 40 patients at night, plus taking all the admissions and plus,
Mhm.
dealing with any, you know, issues or disasters that might crop up. So,
Mhm.
um,
To that point, did you have something like were things like rapid response teams in place where if a patient is hemodynamically unstable, there was a team that responded? If they were
no,
coding, was there a code team?
no,
None
no,
of that. Okay.
no, you are
Yeah.
very much on your own.
Okay.
And as a matter of fact, yeah, I mean, there was an intern in your resident. There was an attending that was theoretically on call, but was kind of unspoken rule that you really wouldn't call the attending. And there was a kind of a joke that went through the training program that sounded like a joke, but wasn't really. It was they would say, feel free to call for help, but just remember it's a sign of weakness. So they laugh about it, but they weren't really kidding. You were kind
Yeah.
of expected to deal with it. Yeah, there was no rapid response team, there was no code team. You might get who was ever in the ICU to come down if a code was called. Um, um, New York Hospital was kind of interesting in that there were the lower floors or the service floors, and the upper floors were in what was called the tower, which was like 20 stories up and was served by like two elevators. So, and they were not fast. I mean, this building was built in like the 1930s. So if there was a code in the tower, it was a good 15 minutes before anybody got there besides you. So I remember coding a guy up there by myself for a long time, the intern, and a couple of nurses until, help arrived, so it
Wow.
could be stressful.
Oh, to say the least. Wow. Yeah.
Yeah,
That sounds
right.
extremely
Yeah,
stressful.
and not ideal, I would say, I mean,
Yeah.
um, yeah.
So do you have the feeling that the implementation of things like code teams have overall helped with patient safety, or do you feel like something is
Oh,
lost by
yeah, no,
having
no,
them? Okay.
undoubtedly. No,
Yeah.
undoubtedly.
Mhm.
Yeah, no,
Okay.
um, there was, I looked back on as I was, kind of preparing for this talk, I was thinking back to, early 1980s. You know, my, my mentors and the people who basically were overseeing these training programs. When you think about it, if these guys were in their late 50s or 60s, they graduated from medical school in the 1940s. Um, and I always remember when we would like complain to an attending about how tough this every third night call rotation was. They would say, "Well, yeah, no, I was on every other night, and I was disappointed. I was missing half the cases." It was that kind of attitude. But when
Yeah.
you think about, I mean, what was training like in the late 40s and 50s? Well, there are no ventilators. There's no CAT scan machines. There's no ultrasound. There's no MRI. There's no open heart surgery, cardiac catheterizations. You had about 4 or 5 antibiotics. You had diuretics, digoxin. So, you would admit patient, put them in bed, and if they made it to the morning, that was great. But if they didn't, they weren't doing a whole lot else. So,
Yeah.
the same training system persisted despite everything getting so much more complicated. And
I
so
see.
I think that, ultimately it just led to, things had to change,
I see.
Yeah,
Well, speaking to that point, now I would really, I'm very excited to bring up this next topic. You trained during the time of the Libby Zion case, which, for those who may not be familiar, and I would love for you to explain it from your perspective because you actually
sure.
were there when it was happening. But this case essentially was responsible for the present duty hour restrictions for residents. So now, for the ACGME, residents are limited to working no more than 80 hours in a 1 week period. So if you could tell our audience what was going on in the context of the Libby Zion case, and if you have details about what caused the series of events that led to that ruling, that would be really helpful.
Certainly, right. So, um, Libby Zion was a woman who was admitted to Cape Cod Hospital in the spring of 1984 during my internship year. She was admitted to another of my co-residents, co-interns at the time. Um, she presented to the hospital with what, in retrospect looked like a like septic picture, septic syndrome. She was looking toxic, febrile, had some altered mental status. Um, there was a concern, that may have been some substance abuse involved. She had a history of psychiatric disease, wasn't able to give a great history, was alone, not sick enough to be in the ICU, got admitted to the medical service. We got cultures and some empiric antibiotics. And over the course of the night, became agitated, had shaking chills. And at the time, this is a drug that we don't use anymore, but at the time, patients who had shaking chills were actually not uncommonly given Demerol, actually. And it sort of stemmed from our experience on the cancer wards. A lot of the cancer patients, especially with like fungal sepsis or receiving amphotericin, sometimes had these terrible shaking chills that actually Demerol did a great job of controlling. So she was given Demerol, but I'm not sure if it wasn't known or wasn't appreciated at the time. She was also taking an MAO inhibitor. And so that combination was catastrophic. Again, in retrospect, this wasn't even a thing then, but it probably led to a serotonin syndrome, um, and ultimate, cardiac arrest, and, wasn't resuscitated. So, you know, again, it was an intern covering 40 patients with a resident. They dealt with this themselves. Horrible, tragic outcome. Nobody debates that at all. So Libby Zion's father was Sidney Zion, who was an editor for the New York Times. And so, as you can imagine, everything hit the fan big time. Um, to the point that, the editorials in the New York Times were insisting that the residents be criminally charged. And they were charged. They were charged with murder. And ultimately, it went to a grand jury, and the grand jury, decided not to indict them. But that's, how serious this was. But the result of this tragedy was that it really shone a light on this crazy training system where people are completely exhausted, working 120 hours a week, staying up 36 hours straight, no supervision. No one came in no attendant came in to help out with that case. Um, and yes, it, led to changes in work rules in New York State, and then ultimately led to changes across the country. But I mean, the one thing that stood out to all of us in that internship class was like, that could have been any one of us. That could have happened to any one of us. The people involved, they were not dumb. They were not careless. It was just, a combination of bad circumstances that was, bound to happen given the way, the system was set up.
Yeah, that is, I think, extremely remarkable. And um, what it makes me think of is just the fact that I think people kind of get the impression that if you're a physician or even a physician in training, it's you are somehow uniquely immune to human error. And I think that's just simply not true. Healthcare has limitations, and the people who work within it also have limitations. And so do you remember the press coverage of I don't know if it was a court case or how it was adjudicated in the legal sphere, but do you remember some of the press coverage about it and how the duty hour restriction rule came about from that?
Well, I mean, the press coverage I say was kind of ugly in that, there was just this drumbeat for like hanging out these residents, and, holding them criminally responsible. I mean, ultimately, when that didn't happen, went on to like the New York State Board of Medicine and things. And I think that's where, the ball started rolling in terms of, taking a look at, how the training programs are set up. And that's what really started the movement to make changes. Yeah.
And then I'm not sure if you were ever involved in any of the national like professional organizations, like whether that's the American Medical Association or your state medical association, but do you remember any commentary from leadership about what these duty hour changes might do to training, or do you have any kind of perspective on that?
Yeah, I don't think I heard too much about that, because as I said, I was in the midst of my training when it happened, and then went on to um, a fellowship program and then into private practice. So, I mean, I I did hear the arguments on different sides. I mean, the reality is that residents and interns, we're we're covering a lot of different, roles for the hospital. It was a good deal for them. As I said, these places like Boston City Hospital, there's no blood drawing team, no IV team, no transport team, you know. So it was going to mean big differences. And it would, and frankly, since most of this, medical training is funded by the government, it meant that somebody had to ante up to cover that. Yeah.
I see. Okay, well, that's how we got to where we are on duty hour restrictions. And then I think one other part of your career that I think was very interesting is that you were learning medicine around the time that the HIV/AIDS pandemic was affecting the US population. And so, can you please explain where you were in practice at the time? And what you noticed when you first started to hear cases of patients presenting with this kind of infection.
Yeah, certainly. Yeah, so early 1980s, HIV AIDS epidemic was really starting to take off, and New York City was certainly one of those places, more particularly affected. In a matter of fact, it was so early in the course of the epidemic that there wasn't a name for it when I started training. I can remember gay-related immunodeficiency, GRID, was an early name for it. Um, there was a lot of you know lack of understanding as to even just simple transmission. I mean, it was clear it was a viral illness. It wasn't clear how difficult or easy it was to get it. Um, it was quite clear that it was deadly. In the early 1980s, from an HIV, an AIDS defining diagnosis to death was probably a year. There were no medications. Um, it was at the same time it was scary. It was also kind of fascinating because there was lots of work being done on developing, effective antiretroviral drugs. And there's, in New York City, there was a lot of that work was being done. Anthony Fauci had been a former resident at New York Hospital, and I remember him coming to talk to us at the time. So you were kind of on the cusp of whatever was going on. Um, but at the same time, it was hard to, witness just how difficult it was to be someone who contracted this disease. It was incredibly isolating. Um, the ancillary staff were often afraid to even go in the room. If they did, they were gowned completely just to go into the room. I remember the food service folks would leave the trays in the hallway. So nursing and house staff had to, bring food into the rooms. Family and friends sometimes would not come and visit because, again, the stigma and fear of contagion and things like that. The other thing that was interesting is I said we had a lot of celebrities at our hospital, and these folks would get admitted, and their charts would have pseudonyms on them. It'd be like John Smith, John Doe, when we all knew it was someone else very, recognizable. And even these famous folks would often have very few people coming in to see them. Yeah.
And when do you think there was an understanding in the medical field that this is a bloodborne illness that can only be spread by certain body fluids? Like when do you think that understanding kind of took hold within the medical community?
Yeah, well, it actually took a long time,
Mhm.
you know, um, until cases like, Ryan White, the hemophiliac, who developed it, and people like Magic Johnson,
Mhm.
so now we have, you know, transfusion related, we have IV drugs, we have heterosexual transmission, Arthur Ashe,
Mhm.
was those, so it took quite some time before it was clear. Yeah.
And what was the process? So, in the early days when patients were presenting, and it may not be 100% clear what is accounting for their symptoms, what kinds of testing was done to identify the causative agent, and what kinds of conditions were they being admitted for? You mentioned AIDS defining illnesses, and so can you speak to a little bit about what it was
Right.
looking like with the presentation?
Yep. So one of the things that made taking care of these folks so difficult is that everything they had was really something. So um, if you had a headache, well, it was toxoplasmosis. If you had a cough, it was pneumocystis. If you had a fever, it might be disseminated MAI. If you had diarrhea, it was cryptosporidiosis. So, everything you did, you seemed to come back with a positive test result. Your blood cultures are positive, chest x-rays are abnormal, head CT scans showed, mass lesions in the brain. So, you name it, they had it. So,
And
yeah.
would you say most of them were admitted to an ICU level of care? Were there special wards for patients with HIV? What was the kind of process for
Yeah.
the process like in terms of actually caring for them within the hospital?
Right. Well, there wasn't really a special ward. They were often admitted to a private room for isolation purposes. Um, Really, the only reason the folks ended up in the ICU was for respiratory failure or hemodynamic instability. So, yeah, pneumocystis, again, at the time I was training, ultimately led to respiratory failure. There was not much that could be done. Um, yeah, so really all over the hospital they were cared for. Yeah.
I see. And then you know, famously, like the way we now learn about the AIDS epidemic, at least in medical school, is that it was this, really, basically a death sentence once a patient was diagnosed with this. And there was, all this stigma, as you mentioned, people just not wanting to even be around their loved ones who may be afflicted with this. Was there any sort of advocacy from the medical community for these patients? And, we also learned that the government at the time was not really interested in having a organized, concerted effort to help these individuals, maybe in the way that, we would now want to gather resources to kind of find answers and help them in a more compassionate way, maybe. But can you speak to a little bit about what the medical community attitude towards these patients was? And were there advocacy efforts from physicians, nurses, people taking care of them?
Yeah, I would say at the time we were mostly just trying to keep our heads above water. These folks are so sick and so difficult to care for. I mean, I know on a, case by case, personal individual level, uh, I can look back and just see compassion from my fellow, residents and physicians for these folks because we could see what they were going through. And they were incredibly appreciative of the care we were providing because, it wasn't coming from other places, it's family and friends and workplaces and things like that. So, I was so early in the scheme of things that I was kind of on to another phase of my training before we were talking about, physician advocacy and other things like that, I have to say,
Yeah, no, that's also a very helpful perspective just to
yeah.
kind of see how things are handled. And so, um, all right, so that was obviously a big moment in your training. And so, what was your first job after completing your fellowship?
Right. So after I completed my fellowship, I took a job in private practice, pulmonary critical care medicine in Connecticut, just in a town called Manchester, just east of Hartford. I mean, talk about the way things have changed. So when I was ready to look for a job, you went to the New England Journal of Medicine and looked in the advertisements. And that's what it was. There was no no online search. Um, um, and it was either so you got a job either just by looking at ads in medical journals or if there was a word of mouth, someone from your program that was hiring someone or an attending that knew someone else in another part of the country. I had finished in Georgetown and was looking to go back northeast again, so I wasn't able to take advantage of any local contacts in the DC area. So I took a job in a small community hospital, which I have to say was very challenging as well. I mean, I ended up joining one other pulmonologist, and I went from every third night call to every other night call for about 4 years, and that's what I blame my gray hair on. Is we covered like three different hospitals in this part of Connecticut. And it seemed like, nobody ended up on a ventilator without one of us being there. So
Oh,
we were intubating patients in the middle of the night. There's a lot of, sleepless nights, a lot of, lost weekends and missed, family events. And so that was a tough way to start. I mean, ultimately, we recruited another doc, so every third was a big improvement. But it was tough. I mean, because in the middle of the night in a small community hospital, it was again me and a nurse.
mm,
That was it. Yeah,
mhm,
there was no in-house anesthesia. Um, there was no code team.
mhm.
It was just the two of us doing the best we could in these situations. So that
Wow.
was
Okay.
that was tough. It was tough. Yeah, especially
Yeah.
dealing with critically ill patients.
Yeah, and that actually makes me think of one other question I was wanting to ask you about your residency days. Um, did you ever have a time in your career when when like a structure, like having a physician assistant or a nurse practitioner, was incorporated into your team, in some way?
Um, yeah, not until not until I was probably about 5 or 6 years into community pulmonary practice.
Okay,
We did hire a nurse practitioner to help us out in the hospital because it was again, this is kind of the days before dedicated, intensivists and critical care physicians. It wasn't a common thing. So, outside of maybe some of the major medical centers, pulmonologists had private practices as well as the ICU responsibilities. So it was a challenge to juggle, going to the office knowing that you might be called back to the ICU in the middle of the day because someone wasn't looking good.
I
So
see.
yeah, so that was really difficult to be able to juggle those two things. Um, but we ultimately did hire a nurse practitioner to help us out, just to help us out with things that were going on at the hospital while we were in the office.
I see. Okay. And your office-based practice, were you seeing outpatient consultations, or what kind of work did that entail? And what
Yeah,
kinds of disease processes were you managing in the outpatient setting?
sure. Yeah, so it was pretty much a straightforward pulmonary consultation practice. So, the usual things, COPD, asthma, lung cancer, pneumonia, pulmonary fibrosis, um, things like that. That was the bulk of it.
Okay.
Yeah. And a lot of it was both consultation and then folks would self-refer too. So, and sleep medicine too. Exactly.
I
So,
see. Okay. Very interesting. And do you have any perspective on how people's attitudes towards smoking cigarettes had changed over time? I don't know exactly when it was, but like I know that people tell me like there was a time when you could smoke in the hospital, like at the nurse's station. I don't know how long
right,
ago that was,
right.
but now I just feel like I get the sense, and I think the data bears this out, that overall, like smoking is not as popular of an activity as it once was. And so, can you
Yeah.
speak to your
Yeah.
experience with that phenomenon?
Yeah, exactly. Yeah. So it was a little before my time when it was actually happening in the hospital, but I definitely worked with people who remembered when physicians and nurses would smoke at the nursing station. And patients were allowed to smoke in their room.
Wow.
Right.
Yeah.
So, so things have changed a lot since then. Um, I mean, yes, I think that, the portion of the general public that smokes has definitely been decreasing. Um, Unfortunately, there's still like enough, harm in the pipeline to keep us all busy in the pulmonary field. But but yeah, it's definitely changing. Um, it was one of the funny things we're talking about X-ray folders. As pulmonologists, we used to have a joke. We could tell how much someone smoked a day uh, by the way their X-ray folder smelled.
Ah,
So patients would often, when they come to see us, the days before EMR, they would go pick up their films at the hospital to bring them in for us to look at. And so if they were sitting in their house and sitting in their car with their X-ray folder, the folders would be reeking of tobacco.
wow.
So
Wow.
you're probably a two-pack a day, or if your X-rays actually smell like cigarette smoke.
Oh my goodness.
Yeah.
Wow. Okay. And in later in your practice, or I guess more recently, you know, I think one of the things that I remember as a medical student is learning about the impact that e-cigarettes were having on, you heard about this like e-cigarette associated lung injury and like all these things. And so, did you ever see a kind of shift where previously patients were smoking combustible cigarettes, and then all of a sudden you're seeing these people who are now um, using e-cigarettes, or, can you speak to that a little bit?
Yeah, no, it was quite popular early on for folks to try to make a break from cigarettes by going from tobacco products to e-cigarettes. And and a lot of my patients did it. I would have to say, and I think the literature bears this out that it's not really a great way to ultimately stop smoking. And a lot of these folks either ultimately went back to tobacco products or became hooked on nicotine products. Um, and the e-cigarettes seem to make it on the market with really not a whole lot of oversight initially. We know what happened with the sale to minors and things like that. But no, I saw a lot of folks who had adverse effects from the e-cigarettes themselves, especially with the flavored e-cigarette products. There seem to be particularly toxic to the lungs. And yeah, and I mean, think of all the heavy metal combustion and other things that goes on with the fumes from that. So it's not a benign alternative, unfortunately.
I see. Okay.
Yep.
And then I guess also something that happened more recently, which I think everyone listening to this will be familiar with, at least within the first few years that people watch it. But the COVID pandemic obviously happened in around the late 2019 to early 2020. And
Right.
so, you spoke to your experience with the AIDS epidemic, where, you had kind of this quarantining of patients, dressing up in full head to toe hazmat suits to go care for them. And so then you had to live through that again when COVID struck. And so,
Yeah.
do you see any parallels between the two, or do you see them as completely distinct? And what was your experience like caring for patients as a pulmonary critical care physician during COVID?
Sure. Yeah, no, there are a lot of parallels, I would say. Um, you know, the onset of illnesses that were, poorly understood, that were, contagious and potentially fatal. I mean, not only fatal to patients, but frankly, healthcare workers were at risk as well. Particularly with the COVID pandemic, I would say. Um, I during my pulmonary um, fellowship, I rotated through DC General Hospital, and there was quite a large AIDS population there. And the risk of blood sticks and transmission through blood sticks and other mucous membrane exposures was real. And there wasn't any treatment. There was no such thing as post-exposure prophylaxis. I had an incident where I was doing a thoracentesis on a patient with really advanced disease, and as I was, withdrawing some fluid, the patient moved, the needle came out of the chest, the fluid splashed on the patient and then splashed into my eyes. DC General Hospital was not a place that was well equipped. We didn't have, I mean, now we just think of PPE as a standard thing, but really, if you had gloves, that's what you had, and there wasn't a whole lot of other protection. So what happened at the time, they send you to occupational health, you get your blood drawn for HIV and hepatitis, and then they tell you to come back in 6 weeks. And so
Kind of medication that they would start you on
there was no medication.
prophylactically, or okay.
There was
Yeah.
none,
Yeah.
zero. So
Yeah.
you either had it or you didn't have it. And I was married at the time, and my wife was pregnant. And so that was a scary 6 weeks.
Yeah.
And
Yeah.
so And so here comes, COVID, you know, a deadly disease, highly contagious, at the stage in my career that I'm 63, so I'm actually at increased risk. I'm in good shape, but I'm at increased risk. And so just kind of making the decision like, how involved am I going to be?
Mm.
But our hospital definitely needed help. We saw how other health systems were completely being overrun. Um, we had about 25 beds available for ICU patients, and the hospital was able to like convert another floor to like double that. We were able to double the number of ventilators we had. But I remember it when things really started getting bad. Actually, we have one daughter, and my wife and I decided to live apart while I was working in the ICU, just because we thought my risk was reasonably high. So it was a scary time. And, for the patients, the other similarity I would say with the AIDS epidemic was just how isolating it was. I mean, you talk about isolation. I mean, um, you know, these poor folks in the final throes of their illness, not being allowed to have all their family members at their bedside, you know. Um, so yeah, it was kind of interesting bookends to my career.
Yeah. So, you obviously have gone through, just lived through so many challenges that the healthcare system at large is facing, but obviously, you're living through it. It's your reality. Sacrificing a lot with this, long call shifts throughout your training and then even in early practice. So now I kind of want to pivot to, how you kind of view everything that you've gone through and like if you had to, I guess, choose whether you overall feel it's worthwhile or whether you think maybe you sacrificed more than you signed up for. So if you could share a little bit about how you would kind of weigh everything at the end of things now that you're almost like I guess a year into retirement, maybe a little bit less.
Yeah,
Yeah. Yeah.
about 6 months or so. Yeah, right.
Okay. Yeah.
Yeah. Um, looking back, I have to feel quite good about my career. I think I made a difference in the lives of a lot of people. In community hospitals that I worked in early in my career, I mean, you know, you were on the front line. If it wasn't you, it wasn't going to happen. And, I think, that gives me a lot of satisfaction looking back on it. Um, you know, I guess, and I went into pulmonary critical care because frankly, I wanted to take care of the sickest patients in the hospital. I did. I enjoyed the challenge. I, you know, um, but there is a sacrifice for that. I mean, um, a lot of lost weekends and lost time with family that you don't get back. I'm not sure I do anything different necessarily. Um, I might, and again, it was a different time where, it wasn't really clear what your options were. I mean, there was just so little information available. Like I had said to you, like I was looking at ads in the New England Journal when I was trying to figure out, and literally when I was finishing, there were like three, so
Oh,
there wasn't a lot of choice. Um, I mean, it's quite different nowadays. I mean, people, and it's different in a good way because I think physicians coming out of training, I mean, quality of life is important and it should be. Um, and so that should definitely factor into things. And I think, institutions have adapted to that.
mhm.
It would be hard to recruit someone to a practice where you're on call every other night anymore. That's
Mhm.
probably not likely to happen. So I think that's for the better for sure.
Great. And then you mentioned that your daughter is also a physician, and so
Yep.
when she expressed interest about entering this profession, were you enthusiastic about it? Did you have reservations about her pursuing this kind of life, or how was that? If you don't mind me asking, it's not
Yeah, no,
necessarily
no,
part of the history, but yeah,
no, that's fine. Yeah, no, my
yeah.
wife and I are both physicians, and we frankly had just kind of assumed that she might, you know, uh, gravitate that way as well.
Hmm.
Though initially she didn't. She, was a political science major undergraduate and, you know, graduated from Boston College and spent a couple of years doing a variety of things, but ultimately came around to it later. She ended up, getting a job at one of the local hospitals, as a research coordinator, and she really was excited about it and wanted to take it on. So she took the long way around, had to do a post back and then go to med school, after the fact. And so, I mean, we we were happy she chose that because we've had fulfilling careers. We wanted to make sure she made a right choice in a career in terms of, she was starting later. She was getting married. She wanted to start a family. So picking the right career that will allow her to do that, very important. Um, and she's close by. And the other thing, that we made certain of is that, my wife and I could help her, with her path as well. So we've been able to do that, which is very gratifying as well.
Great. Okay. I'm happy to hear that. And then I guess as our final question, um, you can have a moment to think about it, but I'd like to know if you have any advice for uh, people who may be considering a career as a physician or who are early in their training. If you have any advice about, perspectives they should maintain as they go along their training journey, or um, just any general advice that maybe you would give to yourself looking back as if you could talk to yourself
Mhm.
as a resident, what kind of advice would you give yourself to kind of help you get through the training and maintain an optimistic perspective?
Yeah, well, one thing I would say is you do have to look out for yourself, um, and don't always accept things as they are because that's the way they were in the past. Um, I mean, because that's the way it started when I trained. I mean, this is the way we do it. This is the way you're going to do it. And that wasn't really the best. It wasn't the best for patients always. It wasn't the best for, physicians in terms of, quality of life, mental health, all those kinds of things. So, I mean, you do have to think hard about what you're willing to sacrifice. It's important to research, if the field you're looking at, what that lifestyle really means. Um, but you know, it's still a great choice for a career. Um, and I would do it again going forward. Yeah, sure. Yeah.
All right, great. Um, Dr. Herrick, I think those are all the questions I had. Is there anything else you'd like to discuss that you think people would be interested to know about, or do you feel like we covered the key points that are salient
No, I think
during
we
practice?
I think we covered it
Yeah.
all. It's been fun speaking with you.
Yeah, no, I mean it's been great to hear about your perspective and everything you've gone through. I think it's extremely educational. And, the point of having these interviews is so you can learn about these developments and changes in healthcare without just, getting the textbook knowledge. I think your kind of lived experience is so incredibly valuable, and I just appreciate your time so much. So thank you so much for everything you shared. It was great.
Thank you. Thank you for allowing me to participate.
Yeah.